but I want to send you guys these out beforehand. By show of hands, who would like the slides beforehand? Like, do you guys like to take notes like electronically, or do you guys want to take paper notes like I print out for you guys? Just so I know how many copies I need to make also. So who wants on the computer? One, two, okay, both. No, I'll send them out. I'm just wondering how many copies I need to print out. Okay. Richard Nixon in the back. All right, cool. So I just sent them out. Ryan texted me earlier. I just sent them out. So if you guys have your tablets or whatever, you guys can take notes. Specifically dermatology, we don't have them in color, but most of the stuff came out pretty good, I think, for grayscale. I try to take the high resolution pictures. All right, let's get started. Let's go through this. It should be quick. Okay, so I was trying to make a table, but I was looking online, and I think this is the best way I could find to like really summarize what these things are before we even get into the nitty-gritty of what everything is. This is how you get everything described to you in any question, right? Usually you don't describe it this way to your colleagues. I mean, you should. You just say, oh, there's a rash. But this is how you're supposed to put it on your physical exam. This is how you're supposed to describe it in medical terminology, and this is how you're going to see it on your exams. Okay, so what's a macule, what's a papule, what's a nodule? So here we have, some imaging of what it looks like, what it's described as, and some examples of it. So just real quick, any small flat area without any, like no nodule, no depression, no elevation is going to be a macule. When you say macule papular rash, that just means there's small areas of macules and there's some raised lesions, so that's your maculopapular rash. Change the papule to less than 1 centimeter, not less than 0.5, and change the, I think it's bulla, it's greater than 1 centimeter also, so it's not 0.5, it's 1. It's the most recent definitions. So the papule where it says solid elevation less than 0.5, change that to less than 1. And all the way down at the bottom where it says bulla, large blister greater than 0.5, change that to greater than 1. Per ABIM, per internal medicine. This is from a dermatology textbook. So nodule, obviously everybody knows what a nodule is. You can actually feel it. It's an elevation. A tumor is just a big growth. Most things, any carcinoma, you would describe it that way. So a plaque, it's a flat elevated surface found on the skin. So that's what a plaque is. When you think of things like psoriasis, that's your plaque. Wheal is just a different type of plaque. This is your urticaria. Vesicles, everybody knows it's fluid filled. Bulla is just a large vesicle. Similar to pustule. And I think everything else is pretty self-explanatory. It's just the big ones, the macule, papule, and the plaques are the big ones that people get confused with, okay? All right, so now that we have that done, let's get right down to it. So the first thing we're gonna talk about is the few high-yield rashes. So what are we looking at? So, So what the diagnosis here? So this is a young patient that comes in, has asthma, has eczema at times, and they get a rash like this. What do you call this? Yeah, atopic dermatitis. And how do you know that? Based on these imaging as well. So what surface is this? And this is, well, popped up. So this is lichenification. And what does lichenification mean? So it's thickening of the skin. And how does it happen? Yeah, so chronic itching causes thickening of the skin, and that's basically called lichenification. And as you said, it presents on the face and flexural surfaces, okay? It's associated with asthma, eczema, and rhinitis. What else is it associated with? Can be, but not usually. Something in labs, lab value. Good. And how do you think you treat this? What else can you use besides steroids? Hmm? Antihistamines, I mean, for the skin, what are you going to use? It's topically, what do you want to use besides steroids? Yeah, so like some emollient, some type of stuff. You don't always have to use steroids. And the one thing I will tell you about dermatology, especially when it comes to high yield questions on the ABIM, most things the answer you're going to say is steroids, right? So what do you think they're going to ask about? The things that don't require steroids. It's not even going to be on the answer choice, even if it is one of the ways you treat it. So try to pay attention to the other ways you can treat things besides steroids. And I mean, these people with atopic dermatitis, they are also likely or likely to get infections by Staph aureus because of all this itching and they breach that dermal barrier. All right, and that's your steroids. All right. I hope this popped up well on your slides. So this is a person's wrist. This is a person's neck. And this rash here. What do you suspect? Without me even having to tell you anything. Good. Why? Yeah, there you go. So it's from object and things. So this is what type of reaction? Good. So these are commonly caused by some metals, some poison ivy, poison oak, and it's the specific chemical is urushiol. That's where it's present in those plants, the poison oak, poison ivy, and things like that. How do you treat this?
Long-term oral steroids.
Avoidance, and then steroids. Long-term. Good. Yeah, so these people usually need a little bit of longer course of tapering topical steroids. We're still on topical steroids. Don't give anybody oral steroids for this stuff. All right. What is this? What does it look like? Happens in kids a lot too. Okay, can be, but how about this? This person was exposed to HSV. Most patients don't know they've been exposed to HSV, but this is sometimes the first manifestation. Dermatitis, it's called, yeah, this is eczema herpeticum. And this is also from your HSV. So what do you think the treatment will be? What's the treatment? It's not steroids. Thank you. Oops. So antivirals, acyclovir is the main go-to. So this is the multiple clusters of vesicles that come around. So this is not your shingles formation, right? Because it's present in all these different dermatomes, usually on the face. And again, it happens a lot in kids. And this usually happens when you have a pre-existing skin condition. Most commonly, this happens in people who have atopic dermatitis. So what we just covered, people who have that have an exposure to HSV, which is just there, and they don't know it. And this happens, and this you're like, oh, it's probably from the HSV that you have that you don't know. What about this at the bottom? It can be cellulitis. How often is cellulitis present bilaterally? That's one of the ways you want to differentiate. And it looks like cellulitis. It's hard to differentiate. What? Stasis dermatitis. So how do you differentiate this from cellulitis? It's usually, cellulitis is usually unilateral and can, obviously you're looking for other signs, right? Fever, leukocytosis, things like that. So treatment. A lot of patients here have this. What are the treatments? Compression stockings. What else? Leg elevation. Last one. It's also topical steroids. But leg elevation, compression stocking, that's the main things. Okay? All right. Next one. So now we're going to the, well, I guess the stasis dermatitis was papilloscomus as well. So what, wait, did I miss something? Oops. I think. All right. What is this? Good. So this is a pruritic flat-topped papule, and it shows on where? It's right here. Flexural. Is this an extensor surface or flexural surface? Okay. And it takes a little while to remit after therapy. One to 2 years. It can come back. And how do you treat this? Topical steroids. And if you have severe or persistent disease, then you jump up to, yeah, so all the, it's like, you can use systemic steroids. Phototherapy is one of the things. This is one of those things that responds to phototherapy if you have persistent disease, and retinoids. Okay. So papuloschimous rashes is just a broad category of any scaly papules that's caused by inflammation of the epidermis. Lichen planus is one of them. This is another one. These are the things you'll see. This is a specific type of this. What? Psoriasis, not necessarily arthritis. So 30% will have psoriatic arthritis. This is your thick, marcated, your red plaques that you see with some scaling right here. It's got several different types, right? So what is this called, by the way, when it happens on the nails? You can have pitting, but when you separate the nail from the nail bed? Yes, that's what that's called. So when you see this, that's what that means, the separation. But that's not specific for psoriasis. But what are the other things in your nails that you see? So nail psoriasis is one of the types of psoriasis, right? So aside from onycholysis, you may say pitting. What else? Yeah, so you're going to see the yellow discoloration. So all that together is pretty good description of what psoriasis is like. So they might just give you this picture. Somebody might show you this picture, and that's all you need to know. That, hey, we're looking at psoriasis. And then you can be asked about whether they have psoriatic arthritis. You can be asked about the leading cause of death. Let's talk. So what's severe psoriasis? It's a certain definition. So they might describe it like, oh, this percentage of his body has this. It's greater than 10% of body surface area. That's severe psoriasis. And the leading cause of death in these people, somebody said it before, they were right. Say it loud. Yes, cardiovascular disease is the leading cause of death. So, so that's nail psoriasis. There's also, the most common form is pretty much what you see here. That's your psoriasis vulgaris. There's also guttate psoriasis, which is, the only thing you need to know about that is it's right after a strep A infection. You can have eruption of your stuff on your back, of psoriasis on your back.
Is it arthritis is non-deforming things? Non-deforming
Psoriatic arthritis is non-deforming, yeah. Rheumatoid is deforming. But I don't know if that's specific for that. Because osteoarthritis is also necessarily non-deforming.
Like on imaging, like if like the nail is cut, if there's like a name, like digits.
Yeah. And that's sometimes really hard to see. The best way, and this applies to all of dermatology, a lot of it is visual, right? So when you see a picture, you don't even necessarily need to read the stem, but at least you have an idea of what you're going into. There's a visual DX on Mixap, but I think you need the full version. If you guys have that, that's really good to review for dermatology. Just go through them, and that's really most of it. So how do you treat this?
Topical steroids,
Topical steroids, what else?
phototherapy,
Phototherapy, what else? Tar, okay. Old stuff, immunosuppressant. What vitamin is usually associated with treatment? What do you want to add for these people because, you know, their skin is involved, and vitamin D. And for severe diseases, you can use systemic stuff. Apremilast is usually for psoriasis, severe psoriasis. It's a phosphodiesterase 4 inhibitor. Good. All right. Okay, so both these pictures are pretty good in telling you what this is, and I think Akari gave it away by saying it starts with a singular annular patch. So what is this? Yes. So what's that patch called that it starts with? How often is that present in these people? Like 50%. So it's not on the, yeah, so on the test, if they tell you it's one of those things that sometimes sometimes pathognomonic for this disease, but clinically you don't see it as often. So this is Pityriasis rosea. That's the herald patch. It starts on that trunk. So you can see, so this is like that fir tree sign they call it. It looks like the tree, like the trunk would be in the middle, and this is like coming out like this. It's flowing downwards. The sign is called the fir tree sign. You can call it whatever you want. It typically starts in the trunk. It's thought to be related to HHV 6 or 7, which I don't think have a name. And the other thing you want to rule out in this is, because it may look similar to what type of syphilis? Secondary syphilis. And what does secondary syphilis usually have that this does not have? Good. What other stuff has palms and soles? Coxsackie A, rickettsia, syphilis, Rocky Mountain spotted fever, which is, yeah, rickettsia. Good work. How long does this take to go away?
Maybe 4 to 6 weeks.
Yeah, so it takes a few weeks to at least some months. And how do you treat it? Do I need to treat it? Yeah, so it goes away by itself, and that's why I asked how long it takes to go away. So it's self-limited. You don't need to treat this. So you don't need topical steroids, and that's when these things start to get high yield, which is why they ask you. Otherwise, it's pretty self-explanatory in what it is. So some things they're going to ask you about treatments. Other things they're going to be like, oh, we gave topical steroids, nothing happened. Then they're probably referring to a more severe form of the disease. Okay. So these are scaly yellow-red patches. They look like they're greasy. Good. Good. So it's in, well, not viral load, what? CD4 counts. So the locations are your face, ears, which is kind of what you see here. This is also more prevalent in people with Parkinson's and Down syndrome. That's the other place you will see it besides HIV and immunocompromised people. And a few things that can cause flares is the same thing that causes flares in everything else: sleep deprivation, stress. So how would we treat this? Good, because it's thought to be from sensitivity to certain fungi like Malassezia, that's the one, yeah. Malassezia, thank you. So that's how you treat it. So you give them like antifungal or selenium or zinc shampoos. Okay, and you tell your patients, let this sit on the skin for at least 5 minutes before washing it off. Don't treat it like a regular shampoo. All right. So you have a 28-year-old female that comes to the ED for a laceration. They clean it, they put some sutures on it, antibiotic cream is applied, and then their occlusive dressing is put on. After 3 days, she comes to your clinic. She's saying she's pretty itchy in the area. You remove the Band-Aid, you see the suture lines are clean, but there's surrounding erythema and some eruptive vesicular lesions. What's the diagnosis? Agreed? Right? Suture lines are clean. So from what?
From the
Patient is exposed to poison ivy about 1 hour ago. What do you do? So if you present less than 2 hours from exposure to poison ivy, the first thing you want to do is get rid of what's on your body. All right. Yes, topical steroids you can use for it, but you want to get it and get whatever's there off. So take a shower. 34-year-old male with a history of IV drug abuse and severe seborrheic. High five. All right. Just quick thing about drug reactions. So the most common drug reaction you're going to get is called, it's not the most common. And it's not something we say often because the, huh? Good, morbilliform. What's morbilliform mean? Yeah, so which one of these is morbilliform? Yes. So it's that, you know, pacules and things coalescing together to form the plaques. So morbilliform, which drugs can cause this type? And it's the most common type. So which drugs can cause this type? Penicillin's one of them. Beta-lactams, and the other big category, sulfa drugs. So that's morbilliform. That's this. And what type of hypersensitivity reaction?
Type 2 or type 2.
There's only so many choices you have here. Oh my God. This is also type 4, guys. Okay. So amoxicillin, like when you use amoxicillin in mono, this is the type of rash you're going to get, and that's your morbilliform rash. Okay. What do we see here? What type of reaction? Good. That's, you know, hopefully everybody has seen some sort of urticaria. What type of drugs cause this? We know a lot of different things cause it, foods and things like that. The drugs, it's penicillin again. You have blood products. What was the other medication that causes this as well? A lot of people take it. Low dose, cardiovascular disease, aspirin. So that's your urticaria. And what's this? It's exactly what it is. Describe what it is. It's a fixed drug eruption. Okay. And if you have a drug reaction and you see systemic symptoms and eosinophilia, what's that called? Dermatological emergency. Stress. The other thing is, so you can also, the last type of, it's not a type of drug reaction, it's a different than this, is a phototoxic skin reaction. And that's specific to one type of drug, which is a type of tetracycline. So they can cause phototoxic drug reaction. And how do you treat them? Good work. All right. Now we're going to talk about some acneiform skin lesions. So what's the diagnosis? So all this is called what? It's called acne. What do we see here? What type of acne? Comedone. What about this? Okay. I'm going to call this severe. There's some nodules, so it's part of inflammatory acne. And that can involve some of the cystic. And so for acne, because we have the different types, right? We have comedone, you can have open, closed, and the inflammatory that can have cystic stuff in it, nodules. Cystic is usually in severe acne. Okay, that's when you should get a cystic. Few nodules in moderate acne, you can have a lot more nodules in severe acne. So then the treatment is based on that. So for, this stuff is always confusing because there's so many different ways. It's like either this is first line, or this is first line, or this is first line. But there are certain things you need to know that are present in each category. All right. So for mild acne, which includes most forms of inflammatory acne and pretty much all forms of comedonal acne, what are you going to use? That's your mild acne, which is what everybody uses. Topical retinoids. Salicylic acid, yes, you can use that as well. So there's different products out there. Some have salicylic acid, the other ones have? No. Benzoyl peroxide, so you can use that. And what else can you use? We're not doing anything oral, right? It's all topical. So what's left? So topical antibiotics. If you have moderate, yes, you can. But you have to, usually you add them with what? So you can either do topical combo. So you can use 2 of what we talked about, topical antibiotic plus benzoyl peroxide or retinoid. Or you can do oral antibiotic plus topical agent. So you're just essentially adding on. That's the only thing, right? This is usually single agent. This is adding on double. Now we have severe acne. This is when you have the cystic or nodular acne predominance, which is what? What's called what? The main one, acetretinone. And what's the brand name? This is, I think, Accutane. So this is from your inflammation of your hair follicle and the sebaceous glands. If you have rapid onset acne, what things are you thinking of? Somebody comes in with rapid onset acne, they're like 20s, 30s. There's a few things that you should start thinking about. PCOS, good. Anybody with congenital adrenal hyperplasia can obviously get it. So based on those 2 things, tumors in what areas can lead to rapid acne? Adrenal tumors and ovarian tumors. The other thing that does come up, because something about pregnancy always comes up, and usually it has to do with acne in this form because of all the drugs we use for acne. There's really only 2 main drugs that are category B. Everything else is C, D, or X. So everybody knows what the categories mean. So category A is what? Pregnancy? Safe. Category B? Safe. No harms have essentially been shown, but they think there might be. Category C? Yeah, there's some proven stuff on animals, not significant studies done on humans. That's category C drug. So that's where you start to change the shift. Category D? No, it's not absolutely contraindicated. That's the difference between X and D. So D, category D drug, means that they have shown harmful effects on humans, but the benefits might outweigh the risk. Whereas category X, the benefits never outweigh the risk. It's all harmful things always outweigh the benefits. So what's category X out of this? Any retinoids are always category X. Always remember that. So your clindamycin and erythromycin are the only category B things that you can really use for acne. So usually when they bring up this type of question, it's always going to be in relation to a young female, and these things you have to think about. So the choices might all be there. You just have to pick the better one.
Are topical retinoids also X?
Yes. Benzoyl peroxide, by the way, the stuff that's on the regular face wash, even that's category C. So, yes. So is salicylic acid, which is in all the face washes. So that's why I said it starts at category B, and the only topical antibiotics are category B. Everything is C. And then minocycline, spironolactone, and doxycycline, they're all category D. Okay? And then obviously the retinoids are always X. All right. What do we have here? Rosacea. What gave it away? Without you reading it. Spares it?
It's an alcohol stress on the
You can get it. So this is rosacea. What is this? Somebody can tell me the name. Close. So this is a rhinophima. I don't know how to pronounce it. So this happens from chronic inflammation. This happens more in men, and it's one of those things that by the picture you're thinking about rosacea. That's it. That's about it. What can you confuse this with? Okay, but what's different about this and SLE? Parvovirus? Yeah, it does. So how do you differentiate this from the mallow rash? What type of, well, I guess we'll get there, but what type of SLE would give you the mallow rash anyway? Not every SLE gives you. All right, so we'll get to that question in a second. So this can involve the nasolabial folds. The butterfly rash that you talk about when you're talking about mallow rash, that usually does not involve the nasolabial folds. Nasolabial folds is this thing right here, where you see those folds. That's it. So this is common in people with light complexions of European, Irish descent. Can be in response to stress, alcohol, things like that, sunlight, photosensitive people. Unlike acne, this does not have what? Because it can be, there's this certain type of this that can be confused with acne. That's the papulopustular rosacea. But the thing they'll comment on is they're going to tell you they don't have this. It's a skin finding that's common in acne. No comedonal lesions in this, okay? Derm is, everything looks the same, so you have to know what the different characteristics are that set them apart from other dermatological lesions. That's how you're going to identify it on the questions, because they might just describe it to you. Okay, so no comedonal lesion, and this can have the nasolabial folds. How do you treat this? Good. What else? There's more ways. Azelaic acid is one. What about another one? Just looking it up. That's one way to do it. Oral antibiotics. So, yeah, so topical metronidazole is one of the big things for this because it's something special to this. All right. What is this? Go ahead. What do you tell these people? What type of people usually have this?
Metabolic syndrome.
Good. So what do you tell these people? Absolutely. Lose weight, everything, that's the answer. What else? What can cause worsening? If you do this, you're causing an increase besides scratch. No, something. It's an activity that some people smoking. So smoking cessation and weight loss. So you have, this is very hard to treat disease. One is because it can spread over a big area. It keeps coming back because it's in those areas that are hard to keep dry. So besides oral antibiotic and antibacterial washes, what else you might have to do with like severe forms of the disease if they're not going away? Yeah, so you want to do IND, and you can also use TNF-alpha inhibitors. All right, on to some common infections. So on the left, I hope this printed out fine on your slides, but you see this depigmentation, right? You guys agree? See that? So what is this? This is an infection. Tinea. What type of tinea? Versicolor. Good. If it happens in your non-hair-bearing skin with limited involvement, then how do you treat it? Okay, creams. If it's in hair-bearing skin, oral. That's the main thing you need to remember about this. How do you diagnose this? Good, and that's the other thing. Yeah, so you see this spaghetti and meatball type pattern in your KOH or potassium hydroxide preparation. It's branching hyphae, that's what you're gonna see. On the right side, singles. I hope that's easy to identify, right? that dermatome. How do you treat this? Good, 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 good. And I think we talked about at some point what type of isolation they need.
Drop it. Contact.
Stay away from pregnant women.
Drop
Babies.
Okay, when do they need, well, they all need contact. When do they need the added one?
activity and
When there's more than one dermatome involved, or they're immunocompromised? Is it droplet or is it airborne? I thought it was airborne because it's a virus. So it's contact plus airborne. Somebody double check that.
We had a patient with herpes zoster ophthalmica. And she was immunocompromised.
Yeah. All right, so infestations, really the main ones. There's three ones. Two of the big ones that show up is, and it has to do with treatment or it has to do with recognizing the infection, but they're usually going to ask you about treatment because it's easy to recognize. Good, and why scabies?
Because they're just the nail burns.
Right, so you look for these burrows. It's in those areas like the finger webs they're going to point out, or on the wrists, and you're going to see this the scratch marks, and you see some burrows around that. So this is scabies. You have to treat all members of the household. So these are the big questions they're going to ask you in terms of treatment. Besides knowing what agent you're going to treat with, how you're going to treat with, what's going to happen to them. So how do you treat scabies? Face down what?
no, it's topical involving the whole body up below the.
Right. What's the agent? What's the agent? No, permethrin. So neck down, take a shower in permethrin basically, right? You have to repeat that after 7 days. What else do you have to do since you're also treating all the household members? What else do you have to do?
All the clothes and bedding into the.
Right. Wash them in high heat. Repeat in 1 week. Permethrin cream from neck down. Repeat in 1 week. And other thing about scabies is these patients are always going to complain about what? Itching. Even after you treat it, it can last for 1 to 2 weeks. That doesn't mean they have active scabies. That's just their reaction to whatever happened, the bites. So they can have long-term pruritus. So that doesn't mean they have new disease, okay? Bed bugs. So this is another thing. They're going to give you a scenario of people moving around, somebody in a dorm, hostel, things like that. How do you treat this? Same thing, right? You wash everything, high heat, and you're going to call someone. And the other one is just lice. It's the same thing. You can use permethrin for bad infestations, but otherwise it's washing everything and cleaning the area. Okay? All right. Neoplasms. What do we see on the left? Both these? And what, okay, so that's seborrheic keratosis. Are they malignant, pre-malignant, not malignant?
It's not malignant, but they show underlying malignancy.
They can be if they're a different thing, but that's the thing. So they're not pre-malignant. They're benign. They're always benign. But because they resemble other forms of cancers, you have to prove it by? Good. And to treat, you do cryotherapy or shaving if they're symptomatic. Otherwise, you just leave it alone. Right? Usually it's present in older people, so you just kind of leave it alone. Like if they cause irritation. Some people end up scratching it and it causes irritation. There's sometimes erythema around it. My grandfather has like 10 of these.
You said you needed a biopsy, though.
Huh?
I thought you said you needed a biopsy. Just if they have a bunch of them, you just have to biopsy one. Or
No. I mean, so if you suspect that it's cancerous, they usually go follow up with the dermatologist. And if you're suspecting, so what type of cancers are you thinking? It can look like melanoma or even squamous cell. So then you do a biopsy. And you'll see, I don't know how many, so in Florida, because we saw so many people over 90, they would be going to the dermatologist like every 2 weeks. They have a new lesion. They're like, oh, I got it checked. It was fine. I got it checked. It was fine. And like 5 months later, they got another one checked. It's squamous cell carcinoma. So you just got to recognize that it's happening. And if you guys see them in clinic, you should document it. Let the patient know, especially if they don't have a spouse. The ones on the back, they wouldn't know about. That's one of those things when people miss a melanoma. If somebody doesn't live with somebody, or if they live by themselves, those are one of the ways that people miss it, and it ends up, being neglected. All right. What's the bottom here? Bottom left.
Basal cell carcinoma.
Good. And what's
Excessive sun exposure.
good? UV light exposure. So this is the most common.
Sorry, I'm missing
Hmm?
it. What did you say?
Basal cell carcinoma, excessive sun exposure. It's from
He's mumbling.
so the basal cell cancers arise from the basal layer, obviously, of the epidermis. How are you going to diagnose these?
Biopsy.
So you can do shave or punch biopsy. Do they metastasize? Rarely, but why are they important? One, it's the most common, so that's why it's high yield, but they cause local destruction wherever they are, right? So then you still want to find and treat them as soon as possible. Once you do treat them, they have a higher chance of recurrence of basal cell carcinoma, and you need to follow up within 6 to 12 months. And then how do you, at the end, treat them?
Mohs excision.
Right, so any excision surgery, Mohs excision surgery, and protection from the sun. All right.
Actinic keratosis.
Okay, so what's actinic keratosis? So,
The pre-malignant for squamous.
good. So these are the pink thin papules. I think this picture is better. You can appreciate them. Pink lesion. Usually you see them a lot on the face, which is sun-exposed areas, maybe on the dorsum of the hands. So they are malignant, pre-malignant, benign. They are pre-malignant. And as Hassan mentioned, the pre-malignant, they usually can lead to squamous cell carcinoma. And for treatment, you just do cryotherapy for most of them. What else can you do? Topic what? It's not a topical steroid you use for these, by the way. So you're going to use the topical like chemo creams for this, because we just said it's pre-malignant. And phototherapy as well. What about here on the bottom? Yeah, so it can show up in a variety of different ways. Basal cell, you saw, how does this differ from basal cell? So by imaging, the few things you want to look out for, how they,
Pearly appearance of the basal.
good. So it's a scaly, pearly appearance as opposed to basal cell. The other thing is basal cell is a little bit more what?
Pearly pink.
It's like see-through, it's translucent, right? So that's the other thing they call it. This has less translucency, more of a silver, scaly, pearly appearance, and that's how you're gonna. All right. This can be painful, and there's certain features that define a high-risk squamous cell carcinoma. One of them is obviously if it's poorly differentiated, if it's on, they call it like a non-glabrous area, which is essentially hairless skin, essentially on your lip areas, things like that. That's high risk. But in terms of the diameter and thickness are the other two important things. So higher risk if diameter greater than centimeter parts, correct?
5 to
All right, so 2 centimeters. Or thickness,
5 millimeters.
millimeter parts, correct? This is also 2. So it's like a rule of 2s with these, okay? And treatment,
Electrode.
you just want to take it out. Take these out when you see them. And the other high yield skin neoplasm is what?
Melanoma.
Good, melanoma. And what these are, so I thought this picture did well in terms of telling us how we diagnose melanoma, what we're looking for. So melanoma, obviously, you're looking for any dark pigmented lesion that gives it away. That's likely a melanoma. You're looking for asymmetry. You're looking for an irregular border, a change in color within the lesion, a diameter greater than 6 millimeters, and evolution of the lesion over time. This is why they need frequent follow-up. Okay? And the reason this is high yield, it's not the most common, even after squamous cell. I think it's the third most common then, but it's very aggressive. It can get metastatic, and therefore, when you do the biopsy, right, so you need an excisional biopsy, because if you do like a shave biopsy, you're not going to get proper staging of the melanoma. Okay? You want to leave like 1 to 2 millimeter margins. That's usually what they say. And it's high yield because it's responsible for the most skin cancer deaths because it's metastatic. And this is what I was saying before. So people miss it on surfaces of the skin they don't look at. So unless somebody else recognizes it, so people without a spouse or people who don't live with anybody, they have more of a chance of having unrecognized melanoma and finding it at a later stage. How do you treat this? Obviously, it's based on stage. You have to stage it first after your excisional biopsy, then you treat it based on that. And so for stage 1 and 2, you would do exactly that. You would do a wide excision of the area. For stage 3, what else do you want to do? Because it involves, what does it involve? Yes, so you want to add on lymph node dissection. I think you can also add infliximab. And then for stage 4, you want to do full immuno or chemotherapy. Cool. Okay. Now, back to our malarash. What is this? Lupus is not good enough. What type of lupus? On the left or on the right?
On the right.
Okay, what's on the left? This is your butterfly malar rash. What type of lupus do you get this in? Acute cutaneous lupus. What type of lupus do you get this in? It's not acute, so this is then subacute cutaneous. So lupus is interesting, and I think obviously, Dr. Tudor, when we delve into rheumatology, we're going to talk about it, but you still have to recognize the various skin conditions. And this is legitimately a question. This came up. This present you with a picture that describe like lupus and describe the duration, and you have to figure out what stage. So you do need to know the different types of lupus. And it helps if you associated them with the skin findings. You can just find the answer right away. So the subacute form has elevated Rho and Law and elevated ANA levels. And these lesions, the other thing the mix-up mentions is they don't scar compared to some other lesions that you can confuse them with. So other stuff to recognize from internal disease, this is just kind of associating pictures and understanding where they're coming from. On the left-hand side, this is somebody who has, it's a GI issue, usually association with, GI. So dermatological manifestation of a GI disease, or also GI diseases. Hep C, so what's this called? Good. So this happens, you get skin fragility in your sun-exposed areas, right? And this happens from certain diseases because, what disease are those first? Let's go over those. Hep C, what else? Not, I mean, that's usually with Hep C, right? So you already know where the issue is. So what other
Hep B.
alcohol-induced liver damage? What else? Hemochromatosis. Okay, so it's a nice group of liver disorders that causes this, and the reason is you get an acquired defect that leads to an accumulation of your porphyrinogens, and therefore they get oxidized into porphyrin that goes to your skin exposed areas and causes damage from the light. That's how it works. So liver issue leads to increased porphyrins. On the right, also associated with Hep C. Good. Okay. What is this? Good. Now, these are the pathognomonic things you're going to see, both in terms of pictures or how they're going to describe it to you. What is this? Heliotropic rash. Good. What is this? Good. What is this? Good. So these are one of those things, again, pathognomonic for dermatomyositis. Now, this can look similar to cutaneous lupus. How you differentiate? The knuckles are spared in cutaneous lupus, but they're a big part of dermatomyositis, and the upper eyelids is the other one. So that's why these things are pathognomonic for them, because this involves knuckles, and this heliotropic rash shows your eyelids, which is not usually present in cutaneous lupus. It can, yeah.
So you said the lupus spares the eyelids?
Lupus, yeah. Lupus doesn't involve the eyelids and doesn't usually involve the knuckles. And which is why the Guttern papules and the heliotropic rash are one of those things that you specifically associated with dermatomyositis. Okay. Which one's what? So there's two here. These two pictures is one thing.
It looks like calcified. It's the
Mm-hmm. So the history of this patient would be end-stage renal disease on hemodialysis for 3 years, right? This is calciphylaxis. It's associated with your chronic end-stage renal disease. How do you treat this? Wound local care if it gets infected, so surgery, surgical excision. But what's something you can give them? That's been shown to benefit. Sodium thiosulfate. So yeah, sodium thiosulfate has been shown some benefit, and if it gets infected, surgical debridement. The other thing is you want to use a low calcium bath when they get dialysis. This is something nephrologists will do. This is just from your calcium and your phosphorus going to the skin. It starts as it's painful. Starts as a painful erythematous lesion, turns into a nodule and a plaque. Then the skin infarcts. So then it gets black by forming the eschar over it. And that's what you see. Yeah, skin is skin. Yeah, that's what it is. On the bottom, what do we see? So this is this could be another thing, but we'll go over that in a second. So pyoderma gangrenosum, and it's associated with what? IBD and what else? Malignancies and some of the other autoimmune diseases as well. How do you treat them? Treat pyoderma gangrenosum. Yeah, you want to treat underlying condition as well. What can you do for the patient at this time? So you won't be wrong with steroids on this one. So you can use steroids. The thing you don't want to do is what? You don't want to debride. Surgical debridement or any trauma to the area can exacerbate it. Actually, the places it forms is on places of trauma. So you don't want to do surgical debridement because it's not an infection by anything, as opposed to the other type of gangrenosum, which is this patient, the neutropenic patient with Pseudomonas bacteremia, has this, which looks very similar. That's why it's also gangrenosum. What is this called? No? Ecthyma gangrenosum. And how do you treat this? You treat the Pseudomonas. Okay, so this, they're both gangrenosums because they look the same, very similar, but you need to know a little bit about the history, so that's how you're going to treat them. All right. 27-year-old female with severe acne who wants to start Accutane, which is the isotretinoin for the severe acne, nodular cystic acne, right? What do you tell her? It's category X, so what does she need to do? Okay, so pregnancy test is negative. Now what? Contraception. OCPs plus another mode of contraception. Because it's category X, she needs to be on OCPs plus another mode of contraception, both during therapy and 1 month after. So that's very important. These are the types of pregnancy questions that you're going to get. What does happen if somebody does take retinoids during pregnancy? Why is it so bad? Why is it category X? Anybody know? Yeah, so like in the beginning of your fetal development, it messes with the HOX gene, which is like where your organs go and your spinal nervous system. So it can cause all sorts of weird issues. So this is why you have to be so careful with these patients. Okay? Yeah, you can use Barrett. So it's like use condoms plus OCPs. It can be IUDs as well. Specific IUD, right? You don't want to use, so there's copper, there's progesterone and all that. So the copper one you can use because the OCPs increase your risk of thrombosis. The copper one doesn't. But condom is also okay, any barrier contraceptive. I think that's it, right? All right, good work. Tina, I need to see you.